after both the presentations are over.
Sure,
Right.
ma'am.
So for the second topic, I would like to call Dr. Mohit, who is consultant pain physician at Artemis Hospital, Gurugram. Over to you, Dr. Mohit. Dr. Achal, please give sharing rights to Dr. Mohit.
Yes.
Thank you, ma'am.
Dr. Aditya, you can stop the sharing now.
Okay, ma'am. I stop the sharing.
My screen visible?
Yes, you can make it full screen.
Is it visible now?
Yes.
Thank you, ma'am, for giving me the opportunity. I'll be talking about continuing with the what Dr. Aditya has told. I'll be talking about a journal named Advanced 3D Anatomical Mapping of Infrapatellar branch of the saphenous nerve and inferior genicular nerve branch to enhance our precision in knee joint denervation. This was originally accepted in October 2024 and was published in Pain Medicine Journal in this year. One second, ma'am. How to get the cursor? I'm not able to get the cursor.
Can you do it now? Dr. Mohit?
Yes, ma'am.
Are you able to move it now? Or you can unshare and share it again.
Okay, okay. Just one second, ma'am. One second, ma'am. I'll just share it.
Just stop sharing and then maybe you can reshare. Are you able to share?
Ma'am, I'm able to share, but I'm not able to show the cursor. Am I able to
You
show
able to move your slides?
Share it again, then probably. No, wait.
Okay, I'll
Share
stop
it again.
There were recent articles published in from 2020 to 2024 stating to ablate the inferior patellar branch of the saphenous nerve. But I met with this article which was published in 2025 this year only, and there was some doubt, and they did a cadaveric study and mapped the infrapatellar branch and the inferomedial genicular nerve of the knee to show that that infrapatellar branch is more of a cutaneous branch. I will be going on with the topic now. The radiofrequency ablation is common non-opioid treatment to manage chronic knee pain. The inferior medial genicular nerve is conventionally targeted on the medial side inferior area. But some researchers has suggested that the infrapatellar branch of the saphenous nerve should also be targeted. There was controversy regarding this. Each of the there were a lot of studies which were presented by Hugh et al., Fonke et al., and Beckwith et al. They suggest that infrapatellar branch of the saphenous nerve should also be targeted. In each of the three studies, they proposed a treatment line which was called as Hugh line, you know, in favor of the Hugh et al. For a RFA strip lesion to capture the infrapatellar branch of the saphenous nerve based on anatomic landmarks. And presently, there is controversy regarding the contribution of infrapatellar branch of the saphenous nerve to the innervation of the knee joint capsule. And the infrapatellar branch is classically described as cutaneous nerve that supplies sensation to the skin of the infromedial aspect of the knee joint. However, it has been reported to have an articular branch. Similarly, this study was also found by they also stated that the infrapatellar branch to be targeted. And as you can see in the diagram, a hue line that was proposed, it was according to an anatomical landmark 4 centimeter medial to the apex of the patella and tibial tuberosity. A vertical line was drawn, and they said that infrapatellar branch of the saphenous nerve will lie in this area. And the infrapatellar branch is particularly an important target in patients with persistent neuropathic pain after total knee arthroplasty. The objective of the study was to acknowledge regarding the relationship between infrapatellar and inferomedial genicular nerve. It's necessary to determine which nerves are potentially captured with the proposed RFA protocols. Therefore, this cadaveric study proposed that the purpose of this study was to map the course of infrapatellar and inferomedial genicular nerve and their branches, and to record and compare the sites of termination of the branches of both these nerves. And based on the results, evaluate the potential capture rate of infrapatellar branch of the saphenous nerve and inferomedial genicular nerve. The method used was there was 7 formalin cadaveric specimens were used, of which 2 were female and 5 were male, with a mean age of 91 years, with a deviation of 6.5 years. The inclusion criteria included no visible signs of injury, pathology, or previous surgery. Layer by layer, following the removal of the skin, the infrapatellar branch and the infromedial genicular nerve branch, their roots were traced and digitized along with any visible bony landmarks using a microscope G2X digitizer. The accuracy of digitizer is plus minus 0.23 millimeter with intra-rater reliability of 0.926 and inter-rater reliability of 0.989. The inter-rater reliability means that inter-rater is when more different raters they combine and give that this nerve has this digitizer has this much millimeter difference, and inter-rater is when the same rater courses the same nerve again and again and finds the variability in this. And in order to digitize the infrapatellar branch and inframedial genicular nerve and their branches, short segments of each nerve were sequentially exposed by removing overlying tissue and then discharged at 1 millimeter intervals through their termination. The infrapatellar branch was dissected first at it lies superficial to inferomedial genicular nerve. The inferomedial genicular nerve was localized as it branched from the tibial nerve, and joined by the inferior medial genicular vessels. And the infrapatellar branch was first localized in the subcutaneous tissue as it pierced the crural fascia. Each branches of both the nerves were traced to their termination by carefully removing surrounding subcutaneous tissue and were discharged throughout their course, simultaneously with bony landmarks. The site of termination of each branch was recorded. The results were for infrapatellar branch. As we can see, it originated from the saphenous nerve in the adductor canal in all the specimens and then either pierced the sartorius or carved around its posterior border to penetrate the fascia lata. As we can see in these two images, the infrapatellar branch, as it penetrates the fascia lata, it gives into either the three branches, the superior, medial, and the inferior branch, namely 1, 2, and 3 in this above image. Or sometimes it gives two branches and sometimes it doesn't branch and continues, which I will be discussing in the next slide. The infrapatellar branch goes anteromedially and then divided into two or three branches or remained unbranched. When it branches into three, there was superior, middle, and inferior branch. And if it branches into two, there were superior and inferior branch, no middle branch. In all the specimens, the inferomedial genicular nerve branched from the tibial nerve in the popliteal fossa, deep to the medial head of gastrocnemius. And in 6 specimens, both the anterior and the posterior branches course deep to the medial collateral ligament to terminate in the knee joint capsule. The anterior branches of inferomedial The anterior branches of the inferior genicular nerve course transversely around the proximal tibial metaphysis, inferior to the medial tibial condyle, and then continued anterosuperiorly to terminate in the inferior medial aspect of the anterior knee joint capsule. The posterior branch goes superomedially from its bifurcation on the periosteum of the tibia to terminate in the posteromedial capsule. Showing the inferomedial genicular nerve in different views. The first, A is anteromedial view, B is medial view, and the third is posteromedial view. As we can see, first, all of these, the black arrows which we can see, this corresponds to the the joining point of lateral ligament, and the two branches from the uh, inferomedial genicular nerve. The green one is the anterior branch. It supplies to the it takes sensations from the inferior medial aspect of the knee joint capsule, and the blue one is the posterior branch, which after bifurcation travels superomedially and innervates the posterior inferior part of the knee joint capsule. And in one specimen, the posterior branch of inferomedial genicular nerve terminated in knee joint capsule posteromedially and did not course deep to the medial collateral ligament. In this image, we can see uh, the relationship between both the two. The pink one is the infrapatellar branch of the saphenous nerve, and the green one is the inferomedial genicular nerve. As we can see, if we, which was proposed, that hue line, if that was proposed, if we look around, make a hue line in this, we can see we are almost targeting both the nerves at that point. If we target along the hue line, the infrapatellar branch is also targeted, and this inferomedial genicular nerve is also targeted. The discussion from this was that infrapatellar branch in this study was found to have a variable branching pattern consistent with previous publication. Furthermore, both Tenet et al. And Kalthur et al. reported that the branches of infrapatellar branch of the saphenous nerve were mostly distributed between the patella and the tibial tuberosity. The finding of this study corroborated with the previous literature, where the branches of infrapatellar branch of the saphenous nerve were found to course between apex and the patella. As we can see in this diagram, the pink one is the patellar branch, and it is the branches are between the apex of the patella and the tibial tuberosity. Furthermore, the Fonke et al. And Gardner et al. Reported the presence of articular branches, which was presented by Dr. Aditya. But in an earlier study done in their laboratory, they found that the articular branches from the infrapatellar branch in 3 out of 15 specimens, only in 3 out of 15 specimens. The rest 12 specimens, they didn't find any articular branch. And most of the studies, including the study which they published, have not found any articular branch and described the infrapatellar branch as a cutaneous nerve innervating the anterior knee joint capsule. So there was this controversy was there from many years, but in this cadaveric study, they found that the infrapatellar branch is mainly a cutaneous branch, and it will ablation of this branch or this nerve is mainly helps post TKR in post TKR patients. The results of the current anatomical study have possible significant clinical implications. Several recent publications have recommended infrapatellar branch as a suitable nerve target of RFA procedures to treat OA-related chronic knee pain. Based on our findings in the study and previous studies, it was observed that infrapatellar branch is most often a cutaneous nerve, suggesting the lesioning of infrapatellar may not relieve chronic knee pain caused by OA. And this is the anatomical variation and showing the hue line with and the and shows the hue line and the branching of infrapatellar and inframedial genicular nerve. And the anatomical variation of infrapatellar branch has implication on its capture rate when using proposed RFA protocols. In as we can see, if we do the but we are doing that inframedial genicular nerve, the infrapatellar branch is very variable, and it to capture it if we are trying to capture it, we may not able to capture it sufficiently. So in conclusion, the infrapatellar branch had variable branching patterns, and the proposed RFA protocol intended to target infrapatellar branch only will also capture the inframedial genicular nerve in all the specimens as it courses to the medial knee joint capsule. Moreover, the infrapatellar branch did not innervate the knee joint capsule and may not be ideal nerve to target the RFA procedures to treat chronic knee pain caused by OA-related pathologies. In these studies also, additionally in the literature, it has been suggested that targeting the infrapatellar branch of the saphenous nerve could be useful to treat chronic post-surgical neuralgia with a cutaneous distribution consistent with other studies. In these two studies, they have told that after total knee arthroplasty, the infrapatellar branch should be targeted, and it gives relief in post TKR patients, not the pain caused by knee OA. Thank you.
Thank you so much, Dr. Mohit. And can I request Dr. Amod Manucha to please give his expert opinion regarding these new targets which Dr. Aditya has described using ultrasound guided? And again, this controversy which has again arrived whether to ablate the infrapatellar branch of saphenous nerve or not. Please unmute yourself, Dr. Amod.
Okay.
Thank you. I think let's start with the good points first. I think both the studies are very good and very well planned. Although I can draw technical flaws in everything, we like, there is always someone who's going to criticize Modi and everyone else. So you can always find flaws in people. But having said that, I feel like I'm in no position to criticize them extensively because they have used innovative ideas. And whenever you start from the basics, which is dissection of the anatomy, and actually going down to the roots and delineating where the nerves are and using technologies such as 3D mapping, the outcomes are going to be different and they are going to be clinically relevant. Although I still don't agree. If you look at the first study, the first line it says is validation. I don't think it is validation in any form, because what they are talking about is where are the anatomical targets. I mean, like I can talk extensively about both the studies, but they're talking about where are the anatomical targets. Whether it translates into clinical improvement or not, we don't know.
Yeah,
Let's
yeah.
start with the
They
first.
have suggested the new targets for ablation using
Yeah.
the ultrasound.
Let's start. I'll give you my peace of mind for both the studies. Let's start with the first study. 5 nerves. How many of us target 5 nerves? How many protocols over the world actually clinically target 5 nerves? Most of them target three. Maybe variable people will target four. Five is not very common. So we don't have a like model to compare is the first step. Second step, you start with, you have got 5 to 10 cadavers, 10 cadavers in the first study you are dissecting. And that too in the age group of 80 plus people. What happens in the young people? Are 10 elderly cadavers representative of whatever happens in the rest of the world? I mean, like, I'm sure listening through the presentation, if you deep dive into the thing, they have used 18 megahertz transducers. They've got two transducers. One is 18 megahertz, one is 6 to 15 megahertz. How many of us have access to 18 megahertz and 10 years of sonography experience? So I mean, like even listening to the techniques, it sounded so fidgety and confusing. Leave aside actually translating them into clinical experience and actually doing it. And when it comes to an osteoarthritic knee, which has got effusion where the collateral ligaments are raised up, how do these things change is another thing. So I think clinically replicating what they have said, if you look for clinical replication, you need to have a simple way of doing things, because you have to not only look at the novices who will be doing this, but also the experienced people. It has to be simplified. They start by saying that we want the neurovascular planes might not be together, the nerves might not be together, and then the two nerves they're targeting in the inferior part, they are using
Same method.
blood vessels to define where you tilt your plane into a different probe. So there is a lot of thing, but what I find most challenging is assessing the depth on ultrasound is very tricky, is what I find clinically. In my experience, I've gone through the whole circle. I started with X-rays, went to ultrasound only, then went to combination of the two, then came back to X-rays. And the newer techniques and the variabilities, I feel respond. You have to look at not only the precision but also the practicality. When I look at the practicality, I feel, despite being an ultrasound enthusiast, I feel that the X-ray gives me an edge, because if you're constantly moving the needle, the patient is not going to cooperate. These are big needles in a painful knee. Sometimes,
Yeah, moreover, all the area around there is so painful,
yeah,
becomes difficult.
and it becomes very cumbersome if you try and replicate their techniques. So I think it is a good step and a very innovative one, but it has a long way to go from lab to the clinical application. That is where I feel the limitation lies. And also, even if it is perfect, the clinical efficacy needs to be proved and it needs to be refined a lot more, where it can find a wider application in what we are doing. That is just summarizing that. And if you look, actually, the two studies are contradicting themselves as well. One is saying that infrapatellar is
Yeah.
not relevant at all, which is an important target they have chosen, which shows the ambiguity we have or the difficult task we have when a person comes and spends a lot of money on the radio frequency and expects 100% relief always. Otherwise,
Yeah.
you are the person to blame who's not been able to give him relief and fix his problems. But yeah, the other thing which I would say is, which I could not understand, I don't know if anyone else understands, the ink technique was innovative. But I don't understand, without the stillet, how do you, with all the tissues, place the needle through all those tissues accurately and be able
That
to
too in
see that,
cadaver.
that too in
That
cadaver.
too in cadaver.
even if it's fresh frozen, and then you can assess the tip very reliably on both the coronal and the axial planes. That I could not understand. I'm like, maybe it's to do with the 10-year skill of the people who are doing it, but then I can see they're MSK physicians, not pain physicians, because they could only locate 2 out of 10 nerves. And when we talked about infrapatellar saphenous nerve, which I think is certainly done better by the pain physicians, and I don't know, I've never tried to see how many I can locate, but I think easily 70% should be locatable, is what I find. Maybe as a branch or as a main trunk, but if you follow it nicely, 7 out of 10 should be, not 10 out of 10, but 7 out of 10 should be identifiable, is what I feel, or maybe 6 out of 10, but 2 out of 10 is kind of, outside the standard deviation, is what I feel. That's my take on the first one. Do you want me to move on the second, or shall we finish with this?
Yeah, I think you move on to second also. Then we'll ask comments from Dr. Ashu.
Okay, so the second one I think has got more practical implication. If you look at the literature, there are two sides of the coin. There will be people who say we have seen the articular branches. There will be people who say there are no articular branches, and we have the contradiction right in front of us, because one study is saying that is one of the landmarks you should be targeting, and the other one is saying no. Okay, so that's number one thing. Number two thing I would say is, in my opinion, whether it supplies the knee joint or not, it should be a part of diagnostic, because I feel a lot of knee pain can come from this nerve. And in my protocols, whenever I have a suspicion, I would do that first. Because even if it's not contributing to the knee joint, it can still contribute to knee pain, especially in trauma situations, especially as they also say in post knee replacement or post surgical
Take care.
case. I always try and do this. Maybe not in everyone, because I have, and in cases where I fail with the geniculars, I think of doing this also. So whether it's supplying the knee joint or the not is an important question, because whether we use that as an RFA target or not is a different issue. But it does contribute to knee pain, which can be confusing with early OA or even otherwise. So it is in suspicious cases worth doing it. But again, in the second study, I think it is a very nicely done. I don't understand the limitations of 3D mapping, to tell you very honestly, but it seems that they have done meticulously millimeter by millimeter dissection, trying to take images and digitalize it, which I think is state of the art. But there might be limitations which I cannot comment on. But again, as I said, knee pain, Hoffa's fat pad pain, all of these, the saphenous nerve can be contributing, and it's worth considering it. But again, 7 specimens, where do we go from there? How can we even generalize from 7 specimens as to what we are going to be doing? But yes, it does address a pertinent question, or goes towards addressing a pertinent question as to whether there should be a target, whether it supplies the knee joint or not. Is again something which I don't target it regularly. But yes, it can be caught in when you're doing RFA. And I remember one of the conferences I attended, this was a question from one of the people who said that every time they do this, they get saphenous neuralgia. And I think that's to do with the depth you are placing, because saphenous nerve is a superficial nerve. So hence the newer techniques are describing going more towards the posterior half and more deeper, which again I find easier to kind of assess with X-rays. So I think if you are more deeper compared to in the posterior half, then the chances of catching the saphenous nerve are a little less, because it's more superficial. So I think that is pertinent to know the anatomy and decide what you do accordingly.
Thank you, Dr. Manu. Okay. I have seen that a few patients post TKR, they present with this saphenous neuralgia, mainly the pain and burning sensation on the middle part of this knee, which does not subside even after post TKR if we do that genicular nerve RF ablation and if we don't target this saphenous nerve. In normal patients also, do you say that doing this targeting this saphenous nerve even before targeting the genicular nerve? Do you have any idea about that? Should we target this nerve first before doing the diagnostic genicular?
Okay.
especially in the patients who present with this medial joint pain?
Okay, firstly, I do not think the saphenous nerve pain is restricted to the medial compartment. I have seen so many where there is whole knee stiffness, not just localized to the medial part. So I have been thinking of writing this up, and I've said it so many times. I've thought about it, but I've never gotten to write down as a letter to editor or present a case on it. Although I have got enough in my in my clinical experience, and I've got the details also. That's number one thing I would say. Number two thing, whenever I have a suspicion, I target this specifically. It takes only 2 minutes to do that. If you're doing genicular, then I would do this first and make them walk. And then if it's not resolved, I go on to do geniculars. If it's resolved, then I don't even think about doing that. That's second thing. Certainly in cases where there is trauma or where I have a suspicion about this being involved, I do that as a routine, as a part of my protocol. But do I do it for everyone? Not really. Just because of financial things. If I was given an ideal setup, I would do this first and then do the genicular diagnostics to see what is happening,
Okay. Thank you so much, Dr. Amod. Ashu sir, Dr. Ashu sir,
Yes.
would you like to please add upon this?
See, I don't have very much experience with the ultrasound because I am primarily doing under fluoroscopy. But what I could find, the target that they have described in first study, more or less they compare with the tip of the needle that we place into our under fluoroscopy part. And we usually do 3 levels, the conventional ones. And the learning is definitely in the second study that they say that in a post-TKR or traumatic patient, you can go with infrapatellar. So we'll try to do that. And conventionally, I've been doing with the now cool radiofrequency and with very good results at all the 3 levels. And sometimes pre-patellar or saphenous. Otherwise, that is all I have to say.
Basically, you believe still those 3 targets, which we normally target using
Yeah.
the fluoroscopy.
And the point to take taken well in this study is about that infrapatellar in second study where they say after post TKR. Yes,
Yes,
I
sir.
get these patients, and probably now we will be trying to do that under ultrasound guidance and try to give a diagnostic block, and if okay, then we can go with the RFA. So this will definitely we are going to take up because we see a lot of patients in our clinics from our orthopedic clinic that these patients keep on complaining the area in that pain in that area. So that is the point, the well taken. But we are very comfortable with the fluoroscopy guided cooled radiofrequency. Even conventional, we were doing with very good results at those 3 level only. So this is what I have to say.
Thank you so much, sir. Dr. Achal, would you please like to summarize the things?
Yes. Thank you for moderating the session today. So I think we launched the 2 new targets, and we had excellent comments from our faculty as well, who has been regularly doing this procedure. So all of us can, learn and add ultrasound to actually really pinpoint the target. So I just want to say, if anyone wants to be a presenter, in our journal club, they can directly message me. So as usual, I'll have typed my number in the chat box, so you can take up from there, and they can directly message me. We would love to have you in our journal club because this is just a learning platform. We all learn from each other. And thank you all for coming. Thank you, Mohit sir. And thank you, Ashu sir. Thank you all the faculty. Good job, presenters.
Thank you.
And good night, everyone.
Good night. Thank you so much.
Good night. Bye-bye.